Yes, I'm Benjamin Levy. I'm a lung cancer doctor. I'm an associate professor at Johns Hopkins School of Medicine. So one of the more complicated issues in thoracic oncology is the treatment of brain metastases and when to use radiation and when to hold off on radiation and consider treatment with systemic agents. I think clearly we have strong evidence that targeted therapies, pills, oral therapies that target specific mutations in lung cancer do a remarkable job of penetrating the blood-brain barrier. And I would make the case that any patient with a known actionable mutation in their lung cancer who presents with brain metastases should be the medical oncologist and radiation oncologist should make a decision whether radiation should be done at all in the brain, given the exquisite activity of these targeted therapies in the brain. What we're learning now is that maybe even immunotherapy may have some activity in the brain, maybe not as much activity in the brain. But we do have early data sets to suggest that patients with lung cancer who have untreated brain mets, if these patients are treated with immunotherapy, there can be responses in the brain. Now, are these responses as robust and meaningful and durable and quick as we see with targeted therapies? Probably not, but we do see it. But I would say that the threshold's a little bit higher for me to not give radiation if I'm going to be giving immunotherapy for a patient. So the scenario that I look at is a patient who, one, doesn't have a genetic alteration in which we're going to start on immunotherapy, and two, their brain metastases are small and asymptomatic with very little edema. I think in that case, one could consider trying immunotherapy first without considering upfront radiation, with a caveat being that you partner with the radiation oncologist and get a quick intervals MRI, maybe 6 to 8 weeks after, maybe after 2 doses of immunotherapy, one could consider re-imaging on the MRI to see if there was a response or at least stable disease. Not every patient obviously needs radiation to the brain. This is, again, a partnership, and the radiation oncologist has to make that decision as well. For patients who have symptomatic disease in the brain or who have edema or have large amount of disease, and again, this is where you have to, everyone's got their own definition of what that is. Those are patients that I don't hold off on radiation. I really want to make a strong push to give radiation first if they're going to be receiving immunotherapy. Again, the discussion is entirely different if they're going to be getting targeted therapy. Then I think the threshold's much lower for me to say, look, we can start with targeted therapy. The response rate in the brain with some of these agents is 80%. Immunotherapy, we have smaller numbers and we don't know what the real response rate is. And we're learning that, yes, these drugs do cross the blood-brain barrier, these checkpoint inhibitors, but maybe not as well as targeted therapy. Does that mean we can't try? Sure, but it has to be for the right patient. It has to be a mutual decision between the medical oncologist and the radiation oncologist. And there has to be a plan to surveil the brain quickly during that time point.